Kia ora. So welcome to the second in this series of presentations, and we're going to be looking at the first of the two acute diabetic emergencies, and in this case we're looking at an acute reduction in blood glucose levels. This is the one we call hypoglycemia. So if this fall in blood glucose is severe and prolonged, it's going to result in a life-threatening emergency. Hypoglycemic emergencies are overwhelmingly associated with clients that are using anti-diabetic drugs. But in the absence of these drugs, the normal hormonal control of insulin is pretty likely to prevent hypoglycemia happening. However, once a patient is using anti-diabetic drugs, there are three ways in which hypoglycemic emergencies can occur. The first of these is an overdose of exogenous insulin. So, if an excessive amount of insulin or another anti-glycemic agent such as metformin is taken, it's going to reach the bloodstream and shift the glucose into the cells. In this situation, glucose that's not required for immediate energy needs is going to be converted to more complex forms. The overdose is going to exhaust the blood glucose levels, and once readily available forms of glucose have been utilised, there's no further supply of energy for the cells to carry out their normal functions. The insulin or metformin is also going to inhibit the more complex stored energy forms from being converted back to glucose, and so the blood glucose levels will fall. The second way this can happen is through an unplanned increase in energy demand. So should our energy demands exceed the available glucose, the exogenous insulin promotes energy storage rather than allowing the processes of gluconeogenesis and glucogenolysis to scavenge the stored glucose in the liver and the skeletal muscle cells. A very common cause of this unexpected increase in energy demand is fever or infection. Essentially, the inflammatory response increases the basal metabolism rate, and it's this that's going to exhaust the available glucose. An increased level of exercise can do the same thing. The third way in which this happens is inadequate energy sources. So simply put, this means that more food is needed. A typical example of this might be failing to eat once insulin has been injected. In all of these circumstances, hypoglycemia is caused by an exogenous source of insulin. The body is not able to regulate this insulin, so once it's on board, it's going to drive the glucose out of the bloodstream and into storage where the body can't access it. The cells of the central nervous system are sensitive to this lack of glucose, and once the blood glucose falls below 3.5 millimoles per litre, we're going to get changes in mentation and consciousness. So while most cells of the body are going to be affected, CNS function is going to be affected early and it's going to be affected severely. So quite often this is where we see the changes that are going to alert us. Initially, patients might appear argumentative or confused, but if the hypoglycemia remains uncorrected, the alterations in mentation will progress to an altered level of consciousness through CVA-like symptoms. It can cause seizures and ultimately the equivalent of a brain injury and death. The management principles for hypoglycemia are pretty simple. What we do need to do is replace the glucose. However, the immediate assessment and actions need to follow the find it, fix it model so we can control immediate ABC issues, reduce risk for the patient, and give us time for further evaluation and treatment. Our next priority is discovery. A couple of points to make here. Hypoglycemia is a not to be missed diagnosis for anyone with an altered level of consciousness. The corollary for this is to take a random blood glucose level for all patients with altered mentation or an altered level of consciousness. The differential for stroke-like symptoms includes hypoglycemia, and fortunately the CPGs in New Zealand are well constructed to reflect this. So in the presence of stroke-like symptoms, a BGL is an early necessity. And finally, a blood glucose level below 3.5 millimoles per litre is likely to cause symptomatic hypoglycemia and this needs to be managed. Treatment is managed on a hierarchical basis. So if the patient can self-administer food or drink, a mix of simple sugars such as lollies, jams, and the like, combined with more complex carbohydrates, are favoured to help prevent a relapse once the simple glucose has been utilised. So the latter, these carbohydrates, might include something like bread or cereals. The lack of ability to self-administer food implies a potential airway disaster if oral solutions are attempted. For this reason, patients with a lowered level of consciousness or who cannot obey commands are not given oral treatments. The preferential management in these situations is IV glucose. Now, there are a couple of risks associated with this treatment. Concentrated glucose solutions will damage soft tissue, so a patent IV is utterly essential. The second risk is that waiting for an IV can delay treatment. As IV access is not always available, intramuscular glucagon can promote the release of stored glucose. This is through glycogenolysis. The injection is an exogenous form of the hormone glucagon. Once in the liver, glucagon stimulates the breakdown or the lysis of glycogen, which releases glucose molecules. Now, this process takes several minutes to release sufficient glucose into the bloodstream to make a symptomatic difference. There is a risk with this delayed response. This is associated with cases where there's an inadequate supply of stored glucose. This might mean the injected glucagon will not have a therapeutic effect for anyone who's malnourished. Now, poor efficacy might be predictable in those with a history of vomiting and diarrhea, where there's chronic alcohol use, where there's been prolonged exercise that's depleted all the stores, if there's been some form of prolonged fasting or malnourishment. And further to this, it might be less effective in the extremes of age and in the presence of sepsis. So while not preferential, glucagon's role in providing energy for the CNS cells is invaluable. Paramedics are encouraged to use this treatment if there are delays in establishing IV access. The downside for the patient is that it can take 15 minutes for the glucagon to have a symptomatic effect, and there's a common side effect of a hangover. Nevertheless, delaying treatment by waiting a long time for an IV offers far worse harm. Thus, glucagon is vital in these circumstances. So let me reinforce this. Do not delay glucagon administration unless someone can establish IV access within or less than 5 minutes. Remember, glucagon's effect can take up to 15 minutes, and should your help be diverted or a patent IV is not possible, then the patient's still 15 minutes away from having the hypoglycemia reversed. So just a quick recap. We initiate treatment when we have a symptomatic patient who has a BGL of less than 3.5 millimoles per litre. If the patient is conscious and obeying commands, we give oral glucose alongside complex carbohydrates. If the patient has a lowered level of consciousness and IV access is available, we would organise the administration of IV glucose. But if that is not available and the patient is still unconscious, we're going to use IM glucagon. Following any treatment, it's important to reassess the blood glucose level, vital signs, and complete a neurological status assessment. We will continue glucose or food administration until the BGL reaches 3.5 millimoles per litre. But if glucagon has been ineffective, we don't give repeat doses. We'd always transport to an emergency department if the BGL does not remain at 3.5 millimoles or higher, or if the patient's vital signs and their abilities don't return to their normal baseline. However, if recovery does go well, we can employ a checklist to confirm this. First off, we ensure that this is a single episode, and this helps rule out complications such as a changing physiological norm or some other form of illness. I just want to make the point that disconfirming evidence is gold in these situations. So constructing the questions to say things such as, tell me about the last time this happened, or can you tell me about the other episodes, might serve to find disconfirming evidence rather than just asking for confirmation with a question such as, is this your only episode? The second point is to ensure there's been no accidental or intentional overdose, and this is going to help rule out the likelihood of a relapse in symptoms or might expose other risk. The third question examines underlying issues such as fever or other illnesses, maybe a physical injury that's going to increase ongoing physiological demand and cause a relapse. The fourth and fifth elements of the checklist are to ensure that physical recovery has been confirmed. Now, you need to be 100% sure that you have a complete set of vital signs, that you've got a complete neurological status assessment, that the BGL readings are intact, and that you've completed a mobilisation test. And you're going to make sure that you very carefully document these. Question 6 is there to establish a safety net should the unexpected occur. And providing a meal and ensuring the patient is eating it is going to help prevent a relapse. A patient information leaflet, written instructions on the summary sheet, all provide a safety net and explanations about what has happened, what to look for, and what to do next if things don't go to plan. Point 9 provides additional safety netting. Now, I'll make the point here, in the cases that involve younger or newly diagnosed patients, paramedics should view this as the need to make a direct referral to the appropriate health provider. That is, the paramedic contacts the health provider to state what the problem is. My last point is that none of these steps is optional. To avoid the whole Swiss cheese scenario and have someone fall through the safety net, all the steps need to be fulfilled. Otherwise, paramedics need to make a very strong recommendation for transport to the emergency department. So let's recap. Hypoglycemic emergencies are most likely to occur in patients that are taking anti-diabetic medications. An overdose of anti-glycemic medications, an unplanned increase in energy demand, or an inadequate dietary input will exhaust the available glucose. The central nervous system cells are very sensitive to low glucose levels. Symptoms are going to appear over a short period of time, and they're going to range from confusion in mild cases through to permanent brain injury when the hypoglycemia is severe and prolonged. Blood glucose testing needs to be performed on all patients that have a change of mentation, a lowered level of consciousness, or stroke-like symptoms. Symptomatic patients with a BGL below 3.5 millimoles per litre who obey commands can be managed with oral treatments. However, those not obeying commands should receive IV glucose unless there are delays in establishing a patent IV. In those circumstances, we're going to use IM glucagon. Glucagon may take 15 minutes to work. Poor nutrition, comorbidities, and the extremes of age are going to reduce its effectiveness, and getting the patient to definitive care or definitive care to the patient should be prioritised. Unless all the requirements on the non-transport checklist are fulfilled, paramedics should make a strong recommendation for transport to an emergency department. Okay, I hope this information has been useful. If you've got any questions, you know how to get hold of us. Ka kite.